we have to keep breaking down that false narrative that willpower is what helps people make change. Because the longer we perpetuate that, the harder it is for people to actually do things that take care of themselves.
That right there is the heart of this entire conversation. Welcome back, my friend, to the Exam Room Nutrition Podcast, your guide to giving better nutrition advice. I'm your host, Colleen Sloan. I'm a PA, dietitian, and I hope you had as much fun as I did last week hearing from 9 other dietitians as we unpack the new dietary guidelines. But today I'm really excited because I'm joined by Dr. Robin Pashby. She's a clinical health psychologist who's going to help unpack how do we support the mental side of obesity care. Because if you've ever had a patient look at you and say, I know what I need to do, I just don't do it, it can feel really tricky to know what to say next. So in this episode, Dr. Pashby shares a clear framework for how to talk about weight without shame, and she introduces this idea of food noise versus shame noise. That is so brilliant. We also get into the emotional side of obesity treatment, why some patients feel safer getting care from GLP-1 pop-up clinics, and what we can do differently so patients actually want to see us. Now, one quick thing before we get started, if you like the way we break this stuff down, you will love my free weekly newsletter. I send resources like quick tips, nutrition news, and conversation starters that you can use in clinic with your patients. You can sign up completely for free at examroomnutrition.com/sign up. So I hope you walk away with something that you can try in clinic this week. All right, let's jump in. Dr. Pashby, I am so excited to finally have you on the podcast. Let's jump right in because a really common phrase that I hear people say, and maybe we've even said it to ourselves, is, I know what to do, I just don't do it. And this can be true for so many things in our lives. So from your perspective, what is really going on when someone says that or even just thinks that?
Thank you for that question. I hear that all the time also. And I always ask this question, what is the it? Because the it is a really small word with really big meanings. So for example, the patient comes in and says, I know what to do, but I just don't do it. And their it is lose 50 pounds. Lose 50 pounds is not a single thing that one does, right? It is a collection of thousands upon thousands of small things that a person does. And therefore, part of the problem is that when we say, I know what to do, but I just don't do it, we're setting ourselves up to be drinking from a fire hose in behavior change. And that is unsustainable and even unapproachable in a lot of times. So what I ask people first is like, what is your it? And how do we break it down?
I love that. I've never heard it explained that way. I also think by patients saying like, I know what to do, like that first part of that sentence also kind of minimizes like what the second part, how easy it actually is to get to that point. Because like you said, it's much more complicated than that. Like if you know what to do, there's a lot of steps that have to happen in order for you to get to the 50 pounds, like your example.
Right. And I will say to people, really, when you say, I know what to do, I hear, I know what I should do. Right. And the should is a big variable there because the truth is, depending on what your goals are, the shoulds vary widely, right? And also, we all know this from the psychology world, that shoulds are often a setup because they don't really tap into who you are, what matters to you, what is your circumstance, environmental, family, social, economic, all of those variables that really do affect your ability to do the various things on your list. So I think that whole slogan, we could pick it apart, but if people listen to nothing else, I will say, think about, I know what to do, but I just don't do it, as dumping out puzzle pieces on a table and saying, be a puzzle. I just want it to be a puzzle. It doesn't work that way, right? First, you have to flip over every piece. Then you have to build the border. Like there's just a step-by-step process that has to happen to get to the end goal. So if you don't know what the goal is, that's number one. And then number two, piece by piece by piece is how every important thing is built.
I also feel like they're coming from a place of shame and of guilt and sort of feeling like, well, I should be doing this, but I'm not. Is that true when someone makes that statement?
A lot of times. And I think, often shame is so hidden that we have to listen between the lines that people actually give us to understand what's happening, right? Shame is an inherent human emotion, as we know. But when people are struggling with issues related to weight in particular, there's such a cultural like, oh, this is just willpower, self control, self discipline, overriding theme that I think we have to assume that people who are struggling are feeling like they're not measuring up. And maybe that's not the case because in some cases, it's not the case. But I think if we start from that assumption, then we start with a gentler, more trauma informed approach. And that sets us up to have a better relationship with people, a better outcome for that patient.
All right. So you had mentioned trauma informed care. And that brings me nicely to my next question, because in clinic, it can feel uncomfortable, nerve wracking to talk about a patient's body size, maybe even their body image if the patient brings it up, without triggering shame. And so I would love if you can teach us some language and some words to use, or maybe something we should be avoiding when we're having these conversations with patients.
So, right out of the gate, the two things that come to mind first are I'm very thoughtful about not commenting on how a patient appears, like looks. So, I never say, oh, you look great if the person is down X number of pounds. And we know that the rate of weight recurrence is significant for a lot of people, right? And those fluctuations in weight have a lot of psychological baggage that comes with them. And so if they go in to see a dietitian or they go in to see a PA or a physician, and the first thing out of your mouth is, wow, you look great, then what happens when they've, put on 10 pounds later? Or something like that. What happens because the patient comes to my office and says, I'm going to go see a different doctor who doesn't know that I just lost that weight. Or I'm not going to go back to that dietitian because I don't want to disappoint them. People are inherently wanting to please our healthcare providers. We want to do a good job. We want to be healthier. We want to do all these things. And so just really watch the language around you look great. Instead, try, it's so nice to see you. How are you feeling? It seems so basic, but I think it's like an instinctual thing that when someone has lost weight, we feel like we need to compliment them on their appearance. So that's number one. The second is asking permission to talk about a person's weight is a requirement to talk about a person's weight, even if that person has made an appointment with you to talk about their weight. Why? Because the person that made the appointment 3 weeks ago may not be in the same psychological headspace as the day they show up for the appointment 3 weeks later, right? They could have put on some weight. They could have had a day where they felt really out of control of their eating the night before. They could have recovered from a twisted ankle and not been able to exercise for those 3 weeks. There's numerous variables that happen in a real person's life that contribute to how they feel emotionally about discussing their weight the day they are in your office. So the more we can say things like, do you want to talk about your weight today? Or is it okay to talk about your weight today? Then we give people permission because in theory, we are in a long-term healthcare relationship with this person, right? And the longer we are in this relationship, we have to recognize that there's going to be variability in the person's willingness to talk. So the first is avoid appearance comments. The second is ask consent or permission no matter what. And then the third is I really encourage anyone listening because statistically speaking, PAs or registered dietitians are also people who are going to struggle with their weight, right? And are also people that I work with in my practice because they have a lot of internalized bias, especially if you are in a healthcare providing position, right? I've had numerous people come to me and say, it's really hard for me to talk to patients about their weight because I don't feel so good about my weight. And what would a patient ever want, to hear advice from me if I look like this or that sort of stuff? So I really encourage anyone listening to be aware of your own internal bias and self-talk. Work on that with your own healthcare provider team and make sure that you don't engage in that sort of self-deprecating comments in front of your patient. And then what you're allowed to do is to hear when your patients say it, right? Like a patient will come in and say like, or you'll sort of like see them tugging on their clothes, right? And you can acknowledge, like, I have days like that too, I know, but it's okay. Like here we can be a really non-judgmental partnership to talk about this stuff. Like, this is hard. And you just give people that permission to struggle without needing to have it all solved for you.
I love that. Like, kind of like you're not alone. Like I see you, your concerns, your nerves, they're valid.
Yes.
That validation, I feel like if a patient can walk out of the room just with that, knowing that they were seen as a person and that their stress and their barriers are valid, like I think that that's a win right off the get-go.
It means they come back.
Mhm.
Right? Because if we know anything about weight management at this point, we know that it's a chronic condition that people need to work on for often their whole lives. And the need level changes, right? Like what you need to do, how much effort you need to put in, how much energy you have to do it. All of those factors change over the course of time. And so remembering that, like, you don't need to get it all in one visit or in two visits. And in fact, I read some research that said that one of the factors that contributed to a decrease in the feelings of partnership between registered dietitians and their clients was the dietitian felt like they were sort of pushing all the information in one or two visits because it doesn't feel then like a partnership. It feels like a sales job, right? Like, here, just do this, you're good. See ya. And like, then it just reinforces, well, now you know what to do. Just go do it.
Yeah, exactly. Now, you mentioned how it's okay to sort of connect with your patient if you've had similar struggles or maybe you're having similar struggles. But I would love your perspective on the fine line between connecting and validating sort of where they're at and following that up with, well, what worked for me is, or I did XYZ diet, maybe you should try that. Because I feel like that's kind of where people would take it. And I just would love your thoughts on that.
Okay, thank you for that. And please imagine a huge red stop sign in your head right now if you're listening to this and that's where your brain goes, right? Put the brakes on that idea because every single person's biology, psychology, environment, social network, and so forth is so unique that there is plenty of evidence that even if you feed people the exact same foods in a hospitalized setting, their bodies react differently, right? So what worked for you, we have no idea whether that will quote unquote work for the other person in front of you. What you can relate on is the experience of struggling with something, right? All healthcare providers have struggled with something. Maybe it's not weight, maybe it's grief, maybe it's professional challenges, right? And so connecting, like using that experience in your own life to try to put yourself in the shoes of a patient that is sitting in front of you and saying, like, oh, I'm so frustrated, or like, why is this so hard? You don't have to relate on the weight level necessarily to know what it feels like to be frustrated, disappointed, upset, angry, feel down on yourself, right? So that's where I want people to connect. I want people to connect on like, yeah, like this stuff of life is really hard. And this is the area that's particularly hard for you today, right now. And quite honestly, probably in context with 1,000 other things in your life that are hard right now. And like, what can we work on together, right? What is one small piece that we can dig into right now together?
I want to unpack the mental side of weight management a little bit before we get into your new book. And so, what are some of your favorite, maybe therapeutic tools or strategies that clinicians can borrow? And think of that person who may be in a weight management clinic or even in primary care. So they may not have an hour-long session with a patient, but what are some kind of quick touch points that we can do to help our patients with that mental challenge and barrier when it comes to weight loss?
Hmm. So, okay, I think there's two different questions here, and it's really important because the mental side is what determines what tools you use, right? And so a patient that comes in with a long history of restrictive eating, dieting, has lost and regained 100 pounds 3 times, has 2 young kids at home, and, is working a 50-hour week job, right? She has a different mental load than your 17-year-old who has struggled with weight since she was 3 and has been, working on diet plans with her mom since she was 5 and has a different load than the 65-year-old man. So I want to just sort of highlight that the mental components of all of these three people differ so dramatically. And we have to think about the tools being applicable to the patient. Just like you wouldn't give a kidney-friendly diet to someone who comes in saying, oh, I have eczema and I really want to help with a different inflammatory process. Like you would think you have to understand the patient in front of you, right? And then apply the tools appropriately. So the first thing people can do is actually ask people about their mental health. Like, do you have a history of mental health struggles like anxiety or depression? Or have you struggled with different sort of disordered eating things like, going long periods of time without eating? Or have you ever engaged in purging type behaviors? You would use different language maybe, but like you can talk about like, have you ever exercised excessively to try to lose weight? Or have you ever made yourself sick? These are okay questions to ask depending on the relationship you have so that you understand the mental health of the person sitting in front of you. Then you can think about the tools that you use. So some tools that people can use are, number one, using assessments so that you know who's in front of you. Number two, using a trauma-informed care approach, which means the assumption that every single client or patient you will work with has a history of very complicated feelings and probably traumatic stress around living with high weight, and that those factors have shaped how they think and see themselves today. So gentleness, compassion, transparency, um, uh, really not like working consciously and purposefully at not re-traumatizing a patient about their weight. Those are a trauma-informed care approach. And then there's some other tools like you can pay attention to their self-talk. So if a patient is coming to you and talking about their weight management routine and their exercise behavior, and then they say offhandedly something like, well, I'm just so lazy, I never get there. Then an intervention you can do is say, hey, I hear you talking about yourself like that. Like that doesn't really help folks actually on this journey. And I would encourage you to get some help in changing that self-narrative, because I know this is hard, but it's not your fault. And that mental piece is an important part of your health and well-being.
I love that. I love telling people that it's not their fault, because really that brings us back to the biologic component of weight management. And it really isn't, it's not their fault. And I think they need to be told that over and over and over again.
Yes.
We either hear people say, like, you need to lose weight because we're concerned, right? They are in a larger body and we have a lot of concerns about their health. And we tell them you need to lose weight to, quote, get healthier. That's sort of the old thinking. And then a newer thinking has emerged lately, over the last 20, 30 years, called health at every size.
Mm-hmm.
And you actually have an interesting perspective with this, and you advocate for health at many sizes. And I love that. And so if you can unpack what you mean by health at many sizes and help clinicians talk about weight and health without that stigmatization.
This goes back to understanding history. If you don't understand why the health at every size movement became so powerful, then you don't understand what you're talking about. You have to think about it in context. So the fat acceptance movement started in the 60s. I mean, in many cases earlier than that, but the 60s is when it really grew in popularity. And I encourage anyone listening to actually go back and understand why that whole movement started. Health at every size is a sort of later iteration of the fat acceptance movement. And it really started and has continued because of weight stigma and bias. And until we start tackling stigma and bias, we are going to have people that say, do not discuss my weight with me. It has nothing to do with my health. Now, we know from much science, right, and much data out there that people have different health outcomes at a variety of sizes and shapes and weights. We also know that very, very high levels of adipose tissue tends to cause people harm, right? And so I think that we have to acknowledge that at very extreme ends of adipose tissue accumulation, people are going to have health outcomes that are associated with that. But there's a whole variety of people at different body weights that can be very healthy. And mental health is part of that equation. So if we are only focused on the number on the scale, and willing to shame our clients or patients to try to force them to that number. We are essentially erasing any health gains by stigmatizing people, shaming people, and so on. Because depression and anxiety, and by the way, eating disorders have the highest lethality of all psychological conditions. So we know that this is a much more complex situation. So I understand why health at every size is in existence, and I fully support the mission to help people claim their health and their autonomy to make their own health choices, which goes way back to what we talked about asking consent before you talk about weight, right? So this is all connected. I mean, I very much practice at a you are in charge of your own health standpoint. That said, I'm also a researcher and a scientist, and I have to explain to people over the course of time that excess adipose tissue can cause problems for people. So we want to do our best within realm to manage that in the context of good mental health. And sometimes those two things are hard to have coexist.
But how do you balance the need to maybe share what the evidence shows about excess adiposity, and not in a way that doesn't make the person feel afraid, but while also possibly accepting them at that larger size? Like, what is the balance?
So I think that weight loss gets mixed up with obesity treatment, because really what we're talking about when we're talking about anti-obesity medications and things is obesity treatment, which is focused on health outcomes, sleep apnea, those sorts of associated conditions. When we're talking about weight loss plans and programs, no one is taking labs and things, right? We're talking about size, basically. So I think if we steer away from focusing on patients' size and instead ask them, what's important to you? Often patients will say, I have a family history of diabetes and I don't want to, go down that road. Or my parent died of a heart attack at 62 and I'm a little afraid of that. That's our avenue in to say, okay, well, in the realm of things that contribute to it, sleep is part of it, stress management is part of it, your nutrition is part of it, your excess adipose tissue is part of it, but also maybe your the neighborhood you live in, all of these factors. So if you put it in context, and it's not well, if you just lost weight, you would be healthy. That's totally untrue. We know that it's a very complex picture. So just appreciate that your patients are really smart and know a lot and also are able to handle complex information when you deliver it with compassion.
Okay, you had mentioned incretin therapy, so I want to talk about anti-obesity medications and really get your opinion and advice on where you think the emotional and psychological challenges are and how we can help our patients, working through maybe the new body image on these medications.
There's so much to say here. I'll try to be succinct. First of all, I will say these are a major medical breakthrough. There's no question about that. Second, I will say that for patients that have lived with lifelong obesity, I have patients every day tell me, this has changed my life, right? And I see it. And I think that we can't underestimate that for the right patient, this can be life-changing. It is not for every patient, right? And again, a very extreme history of restricted eating, which often happens in people living with a larger body because we have been told for decades that the only way to lose weight is to restrict your eating, right? The food noise piece is the biggest psychological side of the house, I would say, that has been really helpful for patients. So just feeling like you can eat half of a sandwich and walk away, or have a scoop of ice cream and move on with your day. These are gifts to people who have dealt 1,000 times with the persistent and a sort of almost obsessive nature of when are you going to eat? What are you going to eat? How much are you going to eat? What these therapies don't touch are what I've started calling the shame noise, which is different than the food noise. So the food noise is, what am I going to eat? What is there to eat? When am I going to eat it? How much should I eat? How much did I eat? When will I eat again? That sort of constant stuff. The shame noise, though, is how does my body look in this shirt? Does this picture make my arm look fat at this angle. I wonder if the camera shows my double chin, right? Sort of non-stop body awareness and intrusive thinking about size and shape and weight. So these therapies don't seem to help that very much. And that's why I think mental health support, in my mind, like, should just be part of the process. Now, I understand that accessibility and all of those are real factors, but I hope people are at least open to the idea that when you are engaging in a treatment for something that is going to potentially change your life, that it's okay to get support for it too. I don't think in general people poo-poo someone getting psychological support if they're undergoing chemotherapy. We say like, yeah, that's a thing, right? You probably need some support to do that. Why is this any different?
Real quick, I want to tell you about the Obesity Medicine Nutrition course. This isn't a vague weight loss management class. It's a complete training for clinicians who want to counsel patients with more confidence. You'll get 13 expert-led lessons that teach you how to evaluate and diagnose obesity accurately, apply behavior change frameworks, guide personalized dietary strategies, and integrate weight loss medications into care plans. There's also a resource vault with motivational interviewing script packs, cheat sheets, workbooks, and a private community so you're not learning alone. Plus, the best part, you get 10 and a half continuing education credits. So head over to examroomnutrition.com/course and use code POD15, POD15 for 15% off. All right, now let's get back to the episode. I so agree with you. And I don't know about you, but I have some concerns when I see these pop-up clinics, these just prescribing clinics come all over the place. I mean, you could literally get anti-obesity medication from like Costco now. And like, I love that it's available and accessible, but I don't know. I have some reservations about the limitation to comprehensive care, that maybe those clients are just receiving the medication and that's it. I would love your thoughts on the availability of these medications without the additional support.
I understand why patients would rather go to Costco, because we can't ignore the history of weight bias and stigma that shows up in medical professional offices almost universally. And so if I'm a person that has lived with 80 or 100 extra pounds on my body for 30 years, and for those 30 years, doctor, dietitian, PA, physical therapist, every single healthcare provider that I have seen has told me, you just gotta eat less and move more. And I have internalized this idea that I have failed to do that because I have been struggling with my weight for 30 years. Why on earth would I walk into a physician's office and say, I'd like to try one of these medications if I can walk into Costco, sign on the dotted line and leave, right?
Yeah.
So we can't extract the fact that there is a real reason that this market is so hot. It's partially just a money grab for a lot of places, but it's also a psychologically seemingly safer option for many patients that have been stigmatized and biased and experienced just outright just discrimination. So there's so many answers to this question. And the first begins with, we have to continue to work at a policy level and a systems level to reduce the bias and stigma that people experience in every healthcare professional's office. If we do that and patients feel like they have a partner in their dietitian or in their PA or in their surgeon or whomever, then they're going to actually say, hey, I want to talk to my so-and-so about this because this is kind of a big deal. Instead of, no way in heck am I stepping in that office. Okay. So there's a systems problem that is giving rise to this issue. So the access issue, if people get access to these meds, I hope that every healthcare provider at least says to them, have you considered working with a team, right? I understand why that avenue is so seductive. I would encourage you as a caring healthcare partner with you to seek additional support.
Thank you so much for that perspective, because I don't think a lot of us, if you've not struggled with living in a larger body, I don't think many of us realize the damage that weight stigma does on an individual and their ability and their desire to seek care. So that makes so much sense why someone would just kind of go unseen
Right.
to get this prescription and then just kind of take this journey on their own because
Right.
they've been shamed their whole life for it. So I really appreciate that perspective. So
Yeah.
thank you for pointing that out.
Can you imagine thinking like, I'll go get my chemo from Costco? No, people want to talk to their doctor. They want to know like, what are the side effects and how do I manage them and what are my outcome potential? Like they're so connected with their oncology team
Yeah.
because they're nervous about what they're using, right? But they'll go and seek these very powerful medications like on the internet. Why? It's not because people want to avoid medical care. It's because they want to avoid the stigma that comes with medical care.
Oh, yeah. So well said. You co-authored a brilliant book called The New Food Fight. And so I'd love for you to let us know what inspired you to write this book. And then if you could share exactly what is this food fight that you're describing?
The inspiration are my patients for literally everything I do, for every podcast, every talk, every book I've read, basically comes from my patients. So the new food fight is, I think the subtitle is like how the weight management and eating disorder fields got so divided and what we can do about it. So as someone who has been in the weight management / obesity world for many, many years, but also been active in the eating disorder community, I realized with my colleagues who co-authored with me, we talk all the time about why don't the two communities connect, right? Because it sets up this false dichotomy that you can either have an eating disorder or you can struggle with your weight and that the two don't intersect. But as a clinician and as a researcher, I see the downstream impact of having this false division where I think one of my favorite lines in that book is something like, what stands between an eating disorder diagnosis and a person living with high weight getting treatment is a clinician who hasn't thought to ask. Because we have all of these assumptions that a person with a, quote, eating disorder looks like, and you can probably fill in the blank, right? Younger, female, very thin, Caucasian. There's lots of biased and outdated stigma associated with that. Likewise, there's a lot of outdated and biased stigma around people living with higher weight that these people don't work on their weight management, don't restrict what they're eating, don't, right? I mean, just these completely outlandish things. The truth is the two often exist, and we're really missing people who could be really well managed if we had clinicians that could bridge those two fields. So that's the whole point of the book.
Okay, you mentioned something really interesting that I'm sure clinicians are going to want to learn a little bit more about of what they should look for. So, yes, in every textbook, on every board exam, we are presented with the female gymnast with a BMI of like 16. And then we're like, oh, it's an eating disorder. Like, oh, it's just comical, honestly. But I really love that you highlight that people in larger bodies can have eating disorders, especially if they've come from a life of um, diet cycling and, weight regain. And so they're often underdiagnosed, just like you had mentioned. But for the clinician sitting there who may be evaluating them just based on how they appear, how can we be a better clinician to diagnose them properly? So what red flags should a clinician be watching for in this population?
So one challenge I'll ask every clinician listening is to ask yourself, if my eyes were closed, would I be asking these questions, making these clinical assumptions, and diagnosing this way? Because my guess is a lot of times the answer is, maybe not actually, right? I might be asking slightly different questions or listening differently. So that's one sort of cool way of thinking about it as a clinician. And what we want to be thinking about, obviously, rate of weight loss, which, by the way, with the new incretin therapies, is something to think about, right? Because we do want to be elevating our awareness of a history of disordered eating, restrictive eating, while we're working with patients on GLP receptor agonists. So that's important. But we want to be thinking about rate of weight loss, total amount of weight loss, but we also want to be thinking about like sort of the psychological expression that people have around fear of weight recurrence. The intense fear, which I say all the time, the minute 1 pound is lost, anxiety notches up a notch. Why? Because the fear of weight recurrence begins, right? The only time people are not fearing weight recurrence is when their weight is going up. Like, then they're mad about it, but they're not like worried that it's going to happen because it's happening. Every other moment, people can be in maintenance. I have patients that have been maintaining a significant weight loss for 15 years. They still worry if their weight goes up 1-2 pounds, right? Think about what that means. It's like, we know that if someone has gone through cancer treatment, there's a thing in psychology known as scanxiety, where when you have follow-up scans, even after you've been, declared cured, that people have a lot of anxiety prior to a scan. The same is true in weight management. Getting on that scale is like a scan every day. Like, is it happening again, right? And so I really want people to be thinking about like understanding that level of fear. And sometimes that level of fear can really be problematic. And that's a sign to me that we want to get people in with a more mental health support. There's, of course, 1,000 other variables that we could talk about, like excessive exercise routines that are, harmful for people or like unsustainable. But also it's like really about the psychology, like really negative body image, inability to see weight change. So I've had clients that will lose 50, 60, 70 pounds and say, I can't see it. I look the same. That's a sign, right? So just be thoughtful. And I ask healthcare professionals to like use a highlighter in your brain as you're listening to your client and be like, oh, highlight that. Okay, I need to like sort of save that for later because that you're putting together pieces of a person's puzzle.
Dr. Pashby, thank you so much. I've just so enjoyed picking your brain and understanding how the mental aspect is so important in obesity management. So thanks for being here. And if my colleagues and my listeners want to connect with you, where would we find you online?
Facebook, Instagram, YouTube, and LinkedIn. And then I have a website. Of course, my practice website is healthpsychologypartners.com, and people can always find more information about me there.
Thank you for all the work that you're doing for our patients, and I hope you have a great day.
Thank you.
All right, well, now it's time for my nutrition notes. Now, there are 2 things from this conversation with Dr. Pashby that I really want you to remember and take back into the exam room with you. The first one is to protect the relationship before you talk about weight. According to Dr. Pashby, that means 3 simple things. Avoid appearance comments, ask permission every time, and be aware of your own internal bias. Even if a patient scheduled the visit to talk about weight, that doesn't mean today, right now, is the right day for them emotionally. A simple, hey, is it okay if we talk about your weight today? Goes a very long way. And you know this, I talk about this all the time. And instead of saying, wow, nice, you lost 5 pounds, you look great, just try saying, hey, it's good to see you. How are you feeling? Those small shifts help patients feel seen as people, not problems, and that's what keeps them engaged in care. And the second thing is to connect with your patient by relating to the experience of struggle, not the solution. Now, I hope this was clear in the episode that connection really does matter, but the connection should be in the shared experience of struggling, not in sharing what worked for you. Dr. Pashby described this as a giant red stop sign. If you feel the urge to say, oh, well, what worked for me was, pause in that moment, because every patient's biology, psychology, environment, and social context are completely unique. What helped you might not help them, and that can actually sometimes do more harm than good. Now, we've all struggled with something, whether that's weight, or maybe it's grief, stress, burnout, parenting, or just life. Use that experience to put yourself in your patient's shoes. And you don't need to fix their struggle or offer a personal success story. Sometimes the most powerful thing you can say is, yeah, this stuff is really hard. Then bring it back to being their partner. Asking them, what's one small piece that we can work on together today? That keeps the focus on support, not perfection. And it reminds the patient that they don't have to carry this alone. And sometimes that validation, being heard, understood, and supported, is the one thing that allows patients to take their next small step forward. Well, thanks for carving out some time for nutrition today. I will see you next week. But until then, let's continue to help our patients be healthier, one exam room at a time.
Free audio post-production by alphonic.com.